I have a brief statement.
Yes,
okay.
that's fine.
Just on behalf of Dr. Clifford Mann, who's the President of the College of Emergency Medicine, and myself, Dr. Richard Wilson, National Chair of the College in Northern Ireland, I'd like to thank the Northern Ireland Human Rights Commission for inviting us to participate in this inquiry. The College of Emergency Medicine is committed to promoting excellence in emergency care. The College itself has numerous functions ranging from education research through to recommending standards and developing guidelines for high-quality emergency care. We as a college have been highlighting the challenges facing unscheduled and emergency care throughout Great Britain and Ireland for a number of years now. The challenges faced in Northern Ireland are not unique to Northern Ireland and may also be considered a worldwide emergency care problem. However, whilst the majority of our patients attending emergency departments in Northern Ireland do receive excellent treatment, there are undoubtedly issues, particularly around crowding and exit block, that causes significant distress for patients, carers and staff. Over the past 12 months, the College has been proactive within Northern Ireland with regards to highlighting particular challenges in this region. The release of the CEM10 and its local Northern Ireland version has been used as a tool to structure engagement with politicians, regulators and responsible bodies for the delivery of emergency care within Northern Ireland. This has allowed us to highlight our concerns about the burden being placed on emergency departments that are far too often stretched to the limit. The College participated in the RCN Summit in February 2014, and we ourselves held two separate emergency care summits at Stormont in April and June 2014. The outcome of these summits has led to the development of 18 key local recommendations for unscheduled emergency care that will be released later this month. These will link in with the College and intercollegiate recent publication prescribing the remedy around emergency care. These publications have had endorsement for the Minister for Health. As stated, the College is committed to promoting excellence and quality in emergency care. We will continue to provide clinical support and leadership when assisting with the CMO and the CNO and the Emergency Task Force over the next number of months. Thank you.
Dr. Wilson, thank you. I'll start by asking a similar question I asked at the first session, which is, what do you think were the underlying causes of the problems that occurred in the Royal Victoria Hospital? And then we'll maybe come to whether you think they are being fixed. But what were the underlying causes to the much and well-documented difficulties that the RQII and yourselves and many others highlighted?
As you know, the Belfast and Social Healthcare Trust report was prepared by my predecessor, President Mike Clancy, and a previous Vice President, Taj Hassan. The report is pretty succinct and spells out the exact points you raised. And as Richard was saying, they're not unique to Northern Ireland, but they may be possibly more acute and severe in Northern Ireland, certainly at the Royal Victoria in Belfast at the moment. Emergency medicine is basically predicated on two sides of an equation. One is a supply side and the other is a demand side. And the simple fact at the Royal Victoria and other departments in the UK is there's a mismatch between the supply of trained, experienced emergency medicine clinicians and the numbers of patients that are attending our departments. And the problem with that is that we end up with a vicious circle where ever more pressure is put upon these departments. It becomes more and more difficult to recruit and retain staff. Added to that, I think there are a number of process issues at the Royal Victoria and indeed other hospitals which require unnecessarily all patients to go through an emergency department before they're admitted to the hospital. This was a not unreasonable patient pathway 10, 15 years ago, but the numbers of acute admissions have risen year on year, and it's simply not the case that any emergency department in the UK was built to accommodate both true emergencies and all other acute admissions to a hospital. And it's necessary to separate those things out. In England and parts of Wales, over the last 10 years, increasingly hospitals have moved to an acute medical admissions unit and acute surgical admissions unit in order to expedite the entry of patients who've been seen by their general practitioners and referred into the hospital, therefore bypassing the emergency department, removing an unnecessary step in the patient pathway and allowing better focus of attention either to the surgical patients, the medical patients, or the undifferentiated emergency patients.
suppose my sort of ancillary question, and this recognises that you represent emergency departments across Northern Ireland. We've very much focused on the Royal Victoria Hospital. Two questions again. One, how much of the issues of the Royal Victoria Hospital pertain to emergency departments across Northern Ireland, and how much are specifically Royal Victoria Hospital, and what makes the difference if there is a difference? And my second is, how confident are you, and obviously without stealing the thunder of the recommendations that are about to come out later in the month, but how confident are you that the issues that have been highlighted and are now in an improvement plan are actually going to make a practical difference in Belfast? So,
I think we should better place to answer that question.
yeah.
With regards to the issues, the major problem that we're having around emergency care systems in Northern Ireland at the minute is crowding, and though that is more evident in some trusts than others, and some trusts have been, to date, have been effective in reducing certainly their 12-hour performance, but they are relevant to all of the trusts. The purpose, when we go back to the major incident in the Royal in January, that largely was a crowding capacity problem. That was largely an exit block problem where we struggled to, in a department, to move patients out of the department. And that the process of escalation, it was evident that was going to occur because we remained in a high escalation status for a prolonged period before that. I know that other departments also struggle throughout Northern Ireland. The solutions to that, as I say, it needs to be a whole system solution. The solutions to that are largely outside of the emergency department. And in the recommendations, many of these will be things that are not things that the emergency department themselves are capable of delivering on. So the problems themselves are generic across Northern Ireland. They're obviously more acute at the moment within Belfast and within the Royal Victoria Hospital.
My third question, in the previous evidence, there was an emphasis on how the, if you like, management communication within the hospital worked well. But when we came towards the final question about the issue, will moving into a new department won't end overcrowding, and my sense was that the issues there are actually about communication between clinicians in hospitals, GPs, and many other actors who are outside of the immediate purview of the trust. What are the management issues there, and are the kind of communication systems that were highlighted within the trust, are they available with GPs and others who, to an extent, control how many people come in through emergency departments?
I think those points are relevant to all acute trusts throughout the UK, and indeed the Republic of Ireland, because the College of Emergency Medicine represents emergency medicine physicians in the Republic as well. I think that the point you touch on there about whether or not you can have the capacity within an emergency department is at the very nub of the problem. There is only a certain amount of capacity that it is sensible to build into an emergency department. The analogy I make is that if the bath is overflowing, you either need to turn the tap off or unblock the plug hole. You do not need a bigger bath. And so simply building larger and larger emergency departments hides the problem rather than solves the problem. The problem is not one necessarily of fixed capacity, it's of flow through the system. And the way to optimize flow, I'm afraid, requires a more system-wide approach, joint sharing of responsibility for the patients, even before and after they've been in your department. Far too often there's an out-of-sight, out-of-mind attitude towards patients in an emergency department. If they're not actually on the ward where they're going to go to, there's often no ownership by that ward of that patient until they arrive. There's therefore very little recognition that the longer the patient is in the emergency department, not only are the outcomes for that patient worse, and there's good evidence for that across the world literature, but of course, every patient that is on a trolley in an emergency department is another trolley that can't be occupied by another patient en route to that department. And so not only is the care of the patient in the emergency department compromised, but care of patients yet to arrive in the emergency department is already compromised by a lack of that flow. The only way to solve that flow problem is to have a shared responsibility for patients from the time you know they're coming to the department, notified by the ambulance service, until the time they leave the hospital. And it's that paradigm shift which is necessary to improve emergency care right across the UK. And all the Royal Victoria has shown really is that it's a particularly acute example of where that isn't currently happening.
Marion.
Good afternoon. I have only one question, and it's really on looking at your experiences of your findings in relation to emergency care for particular groups of patients. And I'm wondering, could you comment on specific learning of high groups, such as those with pre-existing brain injuries or mental health problems or long-term chronic medical conditions, how emergency care meets their needs, and what your suggestions would be to improve the quality of care they receive?
Well, those are key groups, and in many ways I think they're a key barometer of how the whole system is performing. Indeed, the KEO review, which is a review of NHS England at the moment, has made the point, and I think it is generalisable, that any system that looks after the frail elderly, the mentally ill, and the socially disadvantaged well, will look after everybody else well as well. So I think they're a key group to target, because you know that if you're looking after them, all other people will benefit. There are different solutions around that, particularly I think patients with long-term care issues. For many of those patients, spending any time in the emergency department is not terribly helpful to them. They have known diagnoses, and usually an exacerbation or a complication of that diagnosis. Usually that actually isn't in and of itself an emergency medical situation, but one that requires urgent intervention by trained specialists knowledgeable of that patient and that condition. All the more reason, therefore, why those patients should be moved quickly from the emergency department, where they may not necessarily present, onto an appropriate medical or surgical ward to be seen by people familiar both with that patient and that condition. And in general, people with long-term conditions feel most happy when they're on a ward that they recognise because they've been there before, being dealt with by staff who they've been looked after by before, and therefore knowledgeable about that patient. When it comes to patients who have cognitive impairment, either because of brain injury or because of dementia, and similarly to patients with learning difficulties, then it's quite clear that in order to properly care for those patients, you need a higher level of resource than you do for patients who haven't got a cognitive impairment, and you need an appropriate physical environment, particularly for confused patients. It is pretty obvious that actually if your emergency department is so busy that people are now on trolleys instead of cubicles, that environment is far, far from adequate. It makes it difficult to look after them on a one-to-one basis with any sort of privacy at all. And furthermore, the nursing staff in particular of these departments are now trying to run an emergency department in what has basically become a ward, whilst you're waiting for patients who've been there for over 12 hours to be moved. Inevitably, that means that there's a worse patient-to-nurse ratio, and therefore many of the nurses are unable to give as much time to those patients, both as the nurses would wish to give and the patients need.
Thank you.
Thank you very much for giving us your time this afternoon. I really appreciate it, and I'm terribly impressed with the reports that have been that you've either written or your college has written or contributed to in recent years. And I find them terribly helpful. And I suppose a key question for me is there a process in place to ensure that your key recommendations are being implemented? How is the health community and the public at large, how can it be confident that these insightful, really apposite recommendations are being actioned? And which brings me back to the governance issue that I'm often banging on about. It seems to me the governance issue is critical. So just to give, one example, in crowding in emergency departments, there's this recommendation that there must be a hospital-wide escalation policy for when an ED department becomes crowded. You'll be very familiar with that recommendation. So what's the process, what's the mechanism, what's the institution in Northern Ireland that could have oversight of the different hospitals and EDs, and then say, well, actually, that most pertinent recommendation hasn't been acted on maybe at all, or maybe it's been acted on, but it's not quite working as it should. So I'm trying to understand what this mechanism, are there already mechanisms to ensure that this stuff is implemented? And that's a human rights question, actually.
To date, from a college perspective, what we have tried to do is to inform people and to express why we feel that an escalation policy and full capacity protocols are essential to ensure safe and high quality emergency care within the emergency departments. For taking it forward, we will be involved with the task force that's been chaired by the CMO and CNO, and we will have college representation on various groups. We've invited onto that task force, and one of those task force is around patient flow and escalation. So we would hope that in the future that will be a mechanism that we can look regionally, because there are regional escalation policies that are fed by the department. There are, I'm sure, certainly within our trust, and certainly within other trusts, there are other escalation policies around the urgent care side of the system. My experience to date is a lot of that is focuses on what the emergency department can do, and what we need now is to see how the rest of the system responds to the pressures within the system that are being expressed in the emergency department. So for going forward, I think the way we would hope to govern it as a college is to do it through the task force with the regional and then trust perspective.
Thank you. Can I just ask, does the college, have I read or been informed correctly that the college has a sort of inspection audit role, capacity? I'm not saying you should or you shouldn't, I'm just trying to get the information. Do you do inspections?
We do invited service reviews, so we're not an inspectorate organisation.
No.
But indeed, the reason that the visit to the Royal Victoria in Belfast came about was a result of an invitation to the college to come and review, and we have done that in many hospitals. We are a relatively small college. We only have 28 whole-time staff.
Quite a new one too.
And we've only been in existence since 2008, so we don't have the resources either in finance or staffing to be able to inspect on a regular basis all hospitals. But wherever we can, we do attend an invited service review. If I can just pick up a little bit on what Richard was saying, if that's all right. I think that the college is a charity. It has a royal charter, and it's a medical royal college. And it's there really to set and maintain standards in emergency medicine. We don't have any statutory powers other than those to award examination results to people with postgraduate exams. What we can do is make recommendations and hopefully persuade people. And we've worked really, I think, as hard as we possibly could over the last, well, since our inception, to provide constructive criticism rather than be a shroud waiver in any way. Our reports are deliberately aimed at being clear and concise rather than verbose and full of caveats. Sometimes that means they can be seen to be rather blunt, but we rather hope that emergency medicine is all about being didactic and concise, and therefore our reports should be similarly fashioned. What we're beginning to do is to hold people to account to the agreements they have made with us. So when we hold a summit or we're meeting and we prepare a document such as we did last year, and we had the summit in Stormont back in March, and those recommendations come out that people have signed up to across the piece. So we've had chief executives of boards sign up, we've had the chief medical and nursing officers sign up to them. We then expect, after a sensible period of time, to see those recommendations come to pass. And if they don't, when we're asked why there are problems in trust, we'll say, if they've done all the things that they agreed we should be doing as published in our recommendations, then we have little or no criticism of them. If they fail to do the very things that they agreed should be happening, then we will hold them to account and we will be critical of them. And if we have to be critical of them in public in order for action to be taken, then that's fine, because it's all about patient outcomes at the end of the day. And I think the other thing that Richard touched on, and this sounds very glib, and but it's not meant in a glib way. One of the key take-home messages, if people are after a soundbite, it should be, do not ask what the emergency department can do for you. Ask what you can do for the emergency department. Because as I said before, it's all about flow. How can you, as a GP, a district nurse, a paramedic, do something about the timely flow of patients into the department? And how can you, as a physician, a surgeon, a psychiatrist, a social worker, a community team, improve flow of patients out of the hospital and out of the emergency department? And it's ownership of that real problem that will improve outcomes. Otherwise, we will simply produce more and more reports, more and more recommendations. Nothing will change.
So, thank you for this. Do you, frankly speaking, do you think it's helpful to have some outside independent body? I'm not talking about judges and courts, but some outside independent body that could look at your, for instance, your recommendation on an escalation policy, or could look at your recommendation about where you say, you and others say, current contracts lack the mechanisms necessary to ensure that acute care specialists have a fair work-life balance. Really important recommendation, really important point there. So do you think it would help you reinforce your recommendations if it's not just left to you as in your next summit?
Yes.
To say to a CEO, well, actually, you promised to do this and you haven't. I mean, that's terribly important, don't misunderstand me. That peer pressure, really, really important. But would it not help you to have an outside body that can take up these recommendations and prescriptions and ask if they're being actioned? And does that body already exist? If I may ask, what do you think of the RQIA? Is this a body that could be encouraged to take on this sort of responsibility in order to reinforce your fantastic work?
Well, I think Richard will have more in-depth knowledge of the RQIA, so I'll ask him to answer that.
I think we are at a stage, and I think the RQIA report has, within Belfast and regionally has come into place. And I think out of that we have had an outcome with regards to what's moving forward. And I do think regionally we have a greater understanding now with high intention about fixing things. The stage right now is we need to implement the change, and I think we have to allow RQIA and the outcome of that with regards to the task force to deliver and give them time to deliver. Now, if they don't deliver in that time frame, I would actually see within Northern Ireland the college as being an external body who've come in and given recommendations. The things that are in the RQIA report and recommendations aren't really anything new that haven't been recommended in other reports. The key to this now is about implementation. And sometimes I think we can over-regulate or over-observed and sort of over-reviewed. And we actually need to get on with implementing the recommendations from RQIA, College of Emergency Medicine, etc.
And do you see an independent body that's able to blow a whistle in 18 months' time and say, well, actually, we've given you time now, and it's not being done? Do you see such a body already in the landscape of Northern Ireland?
I haven't to date, no.
And not the RQIA? You don't see it filling that role presently?
It can fill that role. I think they may come in at I know that there is a follow-up role to the RQA to look at their recommendations and the progress that's been made against it. So the RQA may be that organisation. I think what we do need to do is we need a period of time where we can implement.
If I can go back as well. You touched on a very important point, and one which many people choose to ignore from our recommendations, which was the issue around terms and conditions of people working in emergency departments. And this is very important, and I think this is an opportunity to get a clear message across. This is not about paying emergency medicine doctors more money. This is about having a safe and sustainable work-life balance. At the moment, on average, each acute trust spends over £500,000 a year on locums to prop up its emergency department, and many departments in Northern Ireland are virtually locum dependent, certainly at middle grade level throughout much of the year, and that's not too dissimilar to many of the other hospitals throughout the United Kingdom. What the college is arguing for is the reason people don't wish to come into emergency medicine, or having started often leave and either go into other specialties or emigrate. And at the moment there's over 450 UK and Republic of Ireland trained emergency medicine trainees in Australia, which is more than the entire deficit that we currently have. What we are arguing is that they see a work-life balance that is simply unattractive compared to other specialties or other professions. Now, nobody goes into emergency medicine thinking it's a 9 to 5, Monday to Friday job. That would be absurd. Clearly, it's a 24/7 job, and there needs to be people there 24/7 to deliver first-rate care to patients, whether they turn up in an acute emergency at 3 in the morning or 3 in the afternoon. What the college argues is that there should be a proportionality between out-of-hours work and annual leave entitlements. Because the reason that people find it unattractive to work Saturdays and in the middle of the night and lots of weekends is because of the opportunity lost to spend time with family and friends. And there's no amount of money that is worth me missing my daughter's first hockey match or somebody's son's birthday or whatever it might be. It's about an opportunity. If you can link in some way annual leave to out-of-hours work, what you then allow the person to do is say, yes, I spend fewer weekends, fewer Saturday nights or such with the family, but overall I have just as much quality family time with my friends and family as people who work a more normal office hour-based contract. The whole point about this is that it should be an equitable contract rather than an identical contract. And if we were to do that, we would undoubtedly reverse the drain of doctors away from emergency medicine, both in terms of enhanced recruitment and, more importantly probably, enhanced retention. It's very easy when we say these sorts of things for people to imagine that we've suddenly become a trades union. And we've not become a trades union, that's for the BMA and other similar organisations. But we are mandated to maintain and raise standards in emergency medicine, and we cannot do that if we don't have a workforce. We have to, as I said right at the start, answer both sides of this equation, the supply of doctors and the demand of patients. We have to make sure that we're doing everything to optimise both sides of the equation so that they're in balance.
If I may respectfully say, you don't become a trade union by recognising that there are human rights issues for your members around their terms and conditions, not just pay, terms and conditions broadly. That's a human rights issue. Well, I've taken the microphone for too long. There are many other questions to ask, but maybe on another occasion. Thank you very much, gentlemen.
I've got one final question, just a supplementary to Paul's. In terms of the work that's been done and your recommendations, and you set out very succinctly and clearly, how you will hold to account those who sign up to things and don't deliver them. In terms of the task force, and what do you think is a reasonable time frame to see the implementation happening in practice?
I think some of these issues around workforce and workforce planning will take a prolonged period of time because we need to train people, and so there are different timescales for different aspects of it. There is an urgency to it. We've had a number of particularly bad winters, and there are work streams around frail elderly, respiratory, etc. And I know all of the trusts are dealing with these in their own individual ways. But though I would like to think that by the winter or by the beginning of next spring that we will have a significant improvement. And I know that the Minister has stated there should be no 12-hour breaches after early November. So there should be some visible and palpable change to the staff in the emergency departments and the patients who use emergency departments in that time frame.
May I add to that as well?
Yes.
So I think we've done some modelling at the college around recruitment and retention, and you're looking at 6 years from starting now with the recruitment rate that we've got to becoming fully staffed in UK emergency departments. By fully staffed, I mean we would have 16 hours a day, 7-day-a-week cover by consultants, and 24 hours a day cover in larger departments, seeing 100,000 a year, or major trauma centres. And in terms of how quickly can you introduce some of these things, I personally think that actually if there's a will, some of these things could be introduced within 4 weeks. So in particular, the crowding guidance makes reference to something called boarding. I personally don't like this term. It sounds unfortunate, to say the least. What it simply means is that when you have a patient who is stable, not in pain, is going to be admitted to a ward, it is far better for them to wait on that ward than wait in the emergency department. This is because evidence shows the patients feel much safer and much happier being on the ward they know they're going to be admitted to than languishing in an emergency department, apparently endlessly waiting for the hope that a bus might turn up. Secondly, we know that if staff on the ward see the patient, then they are focused very much on making sure that everything is done to discharge patients who are safe to discharge in a timely fashion. So they are reviewed more quickly by the doctors that need to review them. The pharmacy is alerted to the fact they need their home medications. The transport is arranged more expeditiously. So this has a very positive effect, both on patient experience and patient outcomes. And it also fundamentally changes the balance of out of sight, out of mind that I alluded to before. The win-win for this is that the ward, instead of getting a patient who happens to be the next person that needs to be admitted to the hospital from the emergency department on the never-ending carousel, would only ever be a patient whose condition was entirely appropriate for that ward. So you would only board a respiratory patient on a respiratory ward, board a diabetic patient on a diabetic ward. By doing that, you automatically reduce the length of stay of these patients because it means they won't have to move from one ward to another during their time. If you can reduce the length of stay of your patient, you will free up more beds, you will decongest the emergency department, and you will turn a vicious circle into a virtuous one. The only thing you need to do this, you don't need to employ a single extra doctor, a single extra nurse, a single extra porter. You don't have to build a ward or anything else. You simply have to change your processes within the hospital. And where this has been done, Leeds, Southampton, other hospitals, particularly in North America, it's shown to be highly effective. The only people that will stand in the way of this will be clinicians and managers out with the emergency department. And they will stand in the way of it because they will fear for the consequences, and that's perfectly reasonable. The only way to address those fears is to pilot it, to demonstrate that actually it's in everybody's interests, and then get buy-in for the process. And where that's been done, that has been the ultimate outcome. So ordinarily, there's a period of disquiet where people think this is going to happen. There's a period where people say this is bound to fail and will work hard to find reasons why it is failing. But once you've driven through that, once you've got ownership of the whole scheme by the chief exec, by the executive team of your hospital, and you push on through it, eventually people realise this is a much better system than what we had before.
Thank you. Same offer as we've made to all those who have appeared before us, which is if you want to submit any written evidence, either work you've already done, and we have much of that, or anything else, or anything you want to elaborate on that we've asked you about today, then that will be extremely welcome. And can I thank you again for candid evidence, and we'll look forward to reading the report later this month when it's published. Thanks very much.